Hello, everyone, and welcome to today's Adult AML Chapter event brought to you by the HealthTree Community for AML program. My name is Katie Braswell, and I'm the HealthTree for AML Community Director. I'm very grateful to have each of you here for our meeting today and for your support in building this Adult AML community. I'd like to let you know that today's session will be recorded, and the recording, along with the slides and any resources we discussed today, will be sent to all registrants via email within 48 hours after the event has concluded. I'd like to quickly walk you through some Zoom meeting tutorial features for those of you who are new to using the platform. We'd love for you all to turn your cameras on if you feel comfortable. Doing so helps us to create a stronger sense of community. You can see on the slide how to turn on your camera. At the bottom of your screen, you should see a microphone and camera buttons. You can click the video icon that says Start Video in order to turn your camera on. With that being said, if you're not comfortable being recorded, you are not required to keep your camera on. Your microphone should be currently off and will be kept off by our team throughout the presentation. During the group discussion, you're welcome to unmute yourself once you're called upon. If you have any questions or comments for our speaker throughout her presentation, please click the chat icon and type them in the chat box. If you're using a mobile device or a tablet, click the three-dot icon that says More and then Chat in order to access the chat box. And lastly, if you would prefer to verbally ask a question or make a comment directly to our speaker during the discussion time at the end, we encourage you to do so. If you're using a laptop or desktop computer, click Reactions near the bottom of your screen and then click Raise Hand. If you are using a mobile device or tablet, you can click the three horizontal dots that say More and then click the Raise Hand button. And now let's get started with today's event. First, I'd like to thank our sponsors, without whom this event would not be possible: Bristol Myers Squibb, Amgen, Genentech, AbbVie, and Jazz Pharmaceuticals. The topic of our event today is titled Understanding Your AML Labs and Bone Marrow Biopsy Results. Here's the agenda for today. I will introduce our speaker, Dr. Margaret Kasner, and she will spend the next 30 minutes or so giving us her presentation. After the presentation, we will open it up for your questions and comments and end the event with a few announcements. So let me take a second to introduce our speaker, Dr. Margaret Kasner. Dr. Kasner is Associate Professor and Chief of the Leukemia Program in the Department of Medical Oncology at Sidney Kimmel Medical College. She is also the Co-Medical Director for the Clinical Trials Office at Sidney Kimmel Cancer Center. Her research focuses on the use of novel agents in myelodysplastic syndromes and acute leukemias. Dr. Kasner so graciously joined us back in February as a guest on our podcast to discuss FLT3 positive AML, and we are so excited to have her back with us today to teach us about a topic that everyone here can relate to, which is deciphering our AML labs and bone marrow biopsy results. And so with that, Dr. Kasner, I'll let you go ahead and take it away.
Thank you. Thank you so much for having me. I'm going to share my screen and start my presentation. Okay, so before I start, let me just say that 4 years of medical school, 3 years of residency, and 3 years of fellowship, and still there are some labs that are a little bit hard to understand. So I did my best to try to boil down the things that you look at in a way that you will hopefully be able to sort of appreciate some of the background to these labs, but this is in no way sort of comprehensive. And so please, that's why your docs are here. So always ask them questions and walk through all of this with them. This is definitely not a replacement for that experience. Having said that, when I started putting together this talk, so I've been doing this for about 20 years, and it's rare that I start a talk where I have no slides, but I haven't talked about this before. So I thought, where should I start? And I thought, well, when I started doing this, we didn't have computerized records. We wrote by hand. And this is the universal way in which we wrote down people's complete blood counts. So we drew that little picture and put the white blood cell count on one side, the hemoglobin over the hematocrit, and the platelets on the other side. And that is the way we did it, because that's what's really the focus or the most important part of any complete blood count. You get all of these other numbers in there, and sometime we're going to talk about which ones to ignore and which ones to focus on, but this is it. This is the beginning. Every medical student recognizes this. And then, sorry, my slide doesn't want to go forward. I don't know why. Oh, there we go. So let's start with a couple of things that are not on that picture that I'm frequently asked about. So one is the red blood cell count. And it provides you with really no additional information above the hemoglobin and hematocrit. And to be perfectly honest, we all ignore that number, and you should too. So I frequently get asked about it, but it doesn't really provide any information for you. So we're going to ignore that one. And we're going to ignore what's called the red blood cell differential, not because it's not important, but because it's not important in your condition, because it is affected. It is a description of what the red cells look like, and it's affected by a lot of different things. So if I was worried that you had like hereditary spherocytosis, I'd be looking at your red blood cell differential, but I'm not. I know that you have leukemia, and the way your red cells look are affected by that, and by other underlying disorders, and by blood transfusions, which many of you probably have as part of your disease process. And so unless your hematologist brings this up with you, I would ignore all of the little things about what your red blood cells look like. And so now we'll go back to this picture and start here working through our way through these, because they are what's important. And so before I go any further, I will tell you that on my first day of my job at Jefferson, somebody I worked with brought me a little thing for my desk, and it said normal is just a cycle on the washing machine. So you guys all get those ranges of normal, right? But the truth of the matter is, even for a healthy person, they may not apply, because the range of white blood cells was determined originally by a group of white men in their 40s. So I never fit in that category, and most people in the room with me now, probably the Zoom room, don't fit into that category. So the normal range of many of these things may not apply to you, but may, you know, the normal for you may be different than the normal in that little range that pops up that makes it kind of look too high or look too low. So white blood cells is a good place to focus. So the normal range of white blood cells is huge, right? It's 4 to 11 microliters, which is really 4,000 to 11,000 per microliter. And that number can be affected by a lot of things. So like I said, it can be affected by age. It can be affected by ethnicity. So up to 50% of individuals who have an African ancestry have a baseline white blood cell count lower than 4, and that means nothing. It's not outside their normal range. It obviously can be affected by chemotherapy, by medications, by viruses. COVID-19, we see it all the time. People's blood counts can be really deranged by having had COVID-19, all kinds of infections, and honestly, the time of day, or something that just annoyed you, right? Anything may affect your white blood cell count. And so what you want to do, like with everything here, is get the normal that you're looking for from your hematologist and focus there. And know that it's not just this number that's important, right? But all of the variables that go into it. And so there, like I said, there are people who went through leukemia treatment and whose white count settles at 2.5, and that is their normal, and that's fine. And then there's hemoglobin and hematocrit. And so I really like this picture because, you know, everyone's always saying the thing about apples and oranges, but actually hemoglobin and hematocrit, although they are physically different things, hemoglobin is a protein in the red blood cell, and hematocrit reflects the percentage of the blood volume that is composed of red cells. They provide you with the same information. Hematocrit is approximately 3 times the hemoglobin. Most of us only use one of them. And so like when you're jotting down your notes in your notebook, 1 is perfectly fine. I use the hemoglobin. Most people who do leukemia do use the hemoglobin. But again, they're sort of directly related. 1 is 3 times the other. Again, the normal range. So for somebody who, is 25 and walking around and doing fine without a diagnosis of leukemia, there are normal defined ranges. But for us, we're good and happy if you're over 7 and not having symptoms or other risk factors that might need you to have a hemoglobin that's higher than that. So a sort of a number that, again, might be acceptable. Like we might all be really thrilled if your hemoglobin is 9, but that falls outside of what we would consider the normal range for somebody who isn't undergoing therapy. And then platelets. So people often ask me, what is a safe platelet number, right? As opposed to what is a normal number, because the range of normal goes from about 140,000 to about 400,000. So huge range of normal. So what we think about is more what is safe. So any platelet count over 10,000 is considered safe to prevent spontaneous bleeding. When people have risk factors like a fever that makes the platelets work not quite as well, most of us use 20,000, although I will tell you that the data for that is not nearly as strong as the data for a 10,000 platelet cutoff. When a patient is bleeding or needs a procedure, 50,000 platelets is considered the sort of safe cutoff. And, again, like everything we're going to talk about today, if your platelets are 49 and you're going to undergo a minor procedure, that is likely extremely safe. It's not like 50,000 makes it some kind of huge difference. If you are going to have neurosurgery, that's usually 100,000. But these are also very fickle. And so what do I mean? If I take your blood at 7 a.m. and 9 a.m. and 11 a.m., I may get very different numbers. And so watching them bounce around is fine and normal. And if your counts on Monday have a white count of 70, a platelet count of 75,000, and on Tuesday it's 72,000, that's completely normal. That is not a change. So I'm going to go back to this and say that although these are the most important, there really are some things that are missing from this original diagram, and that is the differential of the white cells. And a lot of times when you have leukemia, people focus on this, and I think rightly so, because in the white blood cell differential, there is the ever important ANC, or absolute neutrophil count. And these neutrophils, plus their cousins, the bands, are the cells that are responsible for fighting bacteria. And what I usually say is they're responsible for fixing your boo-boos. So if you have sores in your mouth, they're responsible for healing that, or a cut on your hand. And so that is often where we focus. So the definition of neutropenia is actually 1,500, but we don't really usually think about risk factors much until we get to below 500 per microliter, and that's where we would call people severely neutropenic. But I can tell you that any working neutrophils are better than no working neutrophils, and there are patients out there with neutrophil counts of 250,000 that don't get, 250, sorry, that don't get infected and that do fine. And so it's a continuum, but we do like to sort of focus on that ANC, or absolute neutrophil count, as a marker of recovery of normal bone marrow. At a time, we use it to decide whether people should be on antibiotics, antifungals. So it is a really important number, and it's something that your oncologist is likely to talk to you about, and this is where we find it. And the other cells are all part of normal white cell development, and you will see them in variable amounts listed. And again, the kind of marking of normal in those things is a little bit less important than, and if there's something in particular that your oncologist is worried about, I'm sure they'll speak to you about it, or you can ask about it. But really, this is where we focus in terms of the ANC. And so now I'm going to spend the second half of my time talking about the bone marrow biopsy. And the bone marrow biopsy is is more complicated in that it has a lot of information. The people that read bone marrow biopsies at my institution are formally trained hematopathologists who have a really good understanding of all of these tests and how to run them. And so I really encourage you to review all the aspects of your bone marrow biopsy results with your oncologist. But I'm going to do my best to sort of give you an overview of what all of these things are, just so you have a sense of what's being done when this test is set. And so, again, it's complicated, and it's completely okay, and in fact, best to review this with your hematologist oncologist. But the first thing that we see when we do a bone marrow biopsy on the slide, which we stain with these really lovely pink and purple stains, is what we call microscopy or morphology. And what I'm showing you here is actually a normal bone marrow biopsy. What you see is cells, and you see different kinds of cells, right? Some of them are bigger, some of them are smaller, some of them have darker central nuclei, and some of them have lighter ones. And then you see these big white areas, and that is fat. And so it is very normal for our bone marrows to have both cells and fat. And in fact, there is a rule of thumb. So when we're born, all of our bone marrow is full of cells. So it's about 100%. And as we get older, it gets replaced with fat. And by the time we're 50, it's about half that. So the rule of thumb is 100 minus your age should be the amount of cells that are in there. So if you see the words hypocellular, meaning less cells than we expect, or hypercellular, more cells than we expect, that's related to your age. Obviously, people who make it to 100 do not go down to 0, right? There's some kind of tail where it's somewhere around 10 or 15% of the cells eventually, and the rest is replaced by fat. Okay, so now I'm going to share 4 slides that describe how I explain to patients and their families about what is going on in your bone marrow where you get leukemia. Because 1, I think it's very easy to understand, and 2, I think it really helps when you are trying to explain to someone else who's asking you what's going on in your bone marrow. And so, like I just showed you, a bone marrow is actually quite pretty, right? It's purple and pink, and it has all these different cells in it. And to me, it looks a little bit like this, a field of wildflowers. And so this is what you would expect in a normal bone marrow, all different cells, different ages, different colors. And this is leukemia. Leukemia is a weed, and this grows over the normal bone marrow. And so it's not that there's something wrong with the other cells or the other flowers, it's that they have nowhere left to grow, right? So if you wait long enough and the leukemia sort of takes over the bone marrow, there's just nowhere left for those other pretty cells to grow. When we give high dose chemotherapy or medium dose chemotherapy even, what happens is that you can think of it as weed killer. All the weeds and any normal flowers that get stung by the weed killer, they all get kind of killed. And in the middle of the cycle, when your counts are really, really low, right? This is why, because nothing is growing in there and it's just a field of dirt. And so when you're sort of thinking about what you should expect blood counts to look like a couple of weeks after receiving high dose chemotherapy or medium dose chemotherapy, like maybe azacitidine or venetoclax, people's blood counts can be very low, and this is why. Also, if you do a bone marrow in the middle of a cycle and you see this, okay, this means that the leukemic cells and the normal cells have been killed, but it doesn't mean remission. Remission is when the normal cells grow back. We look under the microscope, and again, we see this lovely field of flowers. So in interpreting bone marrow biopsy results, it's important to understand that even if they see no leukemia, it's not remission unless what they do see are normal cells, right? It's a good sign. It's what we're hoping for when we look in there and we don't see anything. But what we need to define remission is this, a normal appearing field of flowers. Unfortunately, what we know about leukemia and about weeds is that if you don't continue therapy, they will creep back up from under this lovely field, right? So the reason we can't cure people in one cycle of chemotherapy, or sometimes two, or sometimes many without a transplant, is because we know in this field that they're sort of lurking under there. Okay, so yeah, outside of the analogy, what are we really looking at when we look inside the bone marrow? We are looking at bone marrow cells, and we are looking at blood cells. The bone marrow cells we're going to ignore for now. They have some fun names like osteoclast. The blood cells, what you see here is on the top, a hematopoietic stem cell, right? So the very first cell that's going to make all of the other cells in your bone marrow. And that cell decides that it will be either a lymphoid cell or a myeloid cell, right? An AML type cell or an ALL type cell. And those cells will develop into all the other cells you see here. So one of the important things to remember is that another name for the precursor is blast or baby cell. So we think of blasts as bad, right? We think of them as leukemia, but actually in a normal bone marrow, a few of those myeloid precursor cells are always there. It's normal to see them. And if you are recovering from chemotherapy, or somebody has given you a growth factor to help you recover from chemotherapy, we even sometimes see a few of these normal growing, regenerating precursors in the blood or in the bone marrow, and that doesn't mean you have leukemia. And so I say this to remind people not to panic. If they're seeing one of these on the differential of a recovering bone marrow or a recovering blood count, talk to your hematologist oncologist. You know, we're in a situation that's different than just a couple of years ago in that you guys often see your labs even before we get to see them, right? It's like instantaneous. People in my office get their blood drawn, they see them on their phone before I come into the room. So don't panic. Sometimes we see these precursor cells and it does not mean that the leukemia is back. Okay. This is called immunohistochemistry. This is when we identify cells by staining those slides that I showed you before. The one that's all brown, that is a positive stain. The one on the other side, that's actually a negative stain. And we used to get a lot of information, and we still sometimes do get information about the types of cells by staining proteins in those cells directly on the slides. And so if you see on your bone marrow results that, you know, the immunohistochemistry stain for CD20, for example, which is something we see on B cells, is positive, it means those cells are positive, are B cells that may be a part of the cancer, that may not be a part of the cancer. That's sort of information that's, you know, you need to know from other things, but here you can see how we do it. But now we mostly use something called flow cytometry. And so anybody who's had leukemia has seen a flow cytometry report. And I think that flow cytometry is a super cool thing. So I'm going to spend just a couple of minutes talking about how we physically do it. What do we do with your cells? So we tag your cells with a little light bulb on one end and a thing that attaches to a protein on the other end. And we send them one by one through a machine. A laser shoots through that and it measures whether the light bulb is glowing or not. And it gives us all kinds of information about cells. And so you can take this sample of blood from somebody and you can turn it into what you're looking at here, which is all of the different kinds of cells, right? So based on what kinds of proteins we make glow, we can tell you if they're lymphocytes or monocytes. We can tell you if they're leukemic cells. We can tell you if they're red cells or debris. We can kind of sort of get rid of those cells. And then we can take out just those cells that we're interested in, just the leukemic cells. And we can learn a lot about those cells, what kind of proteins are on the surface of those cells. So later, when we're looking to see how well the therapy worked, we can know exactly what the personal signal of your leukemia cell, what the signature of flow cytometry signature looks like. And so, you know, just for example, on this picture, you see CD45, and that's on all hematopoietic stem cells. All cells that come from the blood have CD45. So that's a really good marker to make sure we know we're looking at the right type of cells. Then there's something called like CD34 that is a precursor or stem cell marker that's usually on blasts. So all these different really interesting kind of things that we can learn, but this is also like an entire fellowship in pathology. So I'm going to move on, but I really think that all of you will see this report in your bone marrows, and this is what it is, and this is how we use it to identify the leukemia. This is FISH, also incredibly cool. Fluorescent in situ hybridization. And so what are we looking at here? So this is a very common translocation in AML. And what does that mean? It means that normally, right, we all have 2 copies of each chromosome, right? So let's say chromosome 8 has a little gene on it, and chromosome 21 has a little gene on it. And what you should see in a normal situation is 2 of each gene separate, just floating around. But in this case, if you have an 821 translocation, a piece of one gene attaches to the other gene, piece of the other gene floats over to this gene, and you create these 2 fusions. And so you can see that here, right? You have one normal AML gene, one normal ETO gene, and then you have these 2 fusion proteins. And why do we do this? Because when we want an answer very quickly about the really important AML translocations that we will make treatment decisions about, we get this test quickly so we can answer questions quickly. But at the same time, we ask our cytogeneticists to do this, to look at all of the chromosomes. And this is the exact same translocation. The 8 and the 21, where the arrows are, instead of looking normal and equal to 2 8s, 2 21s, you can see that one piece went to the other piece went there, and now there's this weird translocation, and that kind of marks a very specific type of AML. And so we do both these tests, we get different information. FISH is more limited in terms of we only mark for certain things. This will show you every single gene. This is an XX, a female karyotype. But both of those pieces of information are important because they help us make treatment decisions and prognostic decisions about your AML. And then the last thing, the latest and greatest in technology that we're using to help define your AML is what's inside. Even smaller abnormalities than are in the chromosomes are abnormalities in the genes themselves. And so next generation sequencing basically targets regions of genes, a bunch of genes at the same time. It depends what lab. I think our lab at Jefferson is now doing upwards of 50 to 60 genes at the same time. And we look at these particular genes, right? And we know that if you have an abnormality in one of them, it may portend a better prognosis, or if you have an abnormality in another, it might portend a worse prognosis. Or if you have, an IDH mutation, we might have a pill to address that mutation. And so when you read the reports, they often look kind of like alphabet soup because there's all these names of genes. But we sort of know and understand what they are, and we're looking for specific things. And I also include PCR, or polymerase chain reactions, which we use for a few genetic abnormalities, in particular FLT3, internal tandem duplicate, because that can be missed on next generation sequencing, and we don't want to miss it. So we do a separate and special test for that. So you'll see that often separately from the next generation sequencing panel. And so this you'll often see on a bone marrow, but can also be done on blood work. And so I know that was a lot. I love this. I got you a bunch of stuff, and that was just the tip of the iceberg. And so I am more than happy to answer questions for you. This is my leukemia team at Jefferson. We took this in the beginning of the pandemic, but we're all still here and still available, and unfortunately still wearing our masks at work, because we're still sort of battling this pandemic. But I'm happy to be together here with all of you in Zoom, maybe next time in not Zoom.
Something we've gotten very good at over the past 2 years, that's for sure. Thank you, Dr. Kasner. That was excellent. It was a lot, but super informative and something that we'll send out the recording for so you all can watch again and again and reference. So thank you so much. I'd like to, let's see, share my screen now. We can open it up for questions. Go here to remind everybody how you can ask your questions to Dr. Kasner through the chat feature if you'd like to type them out or if you'd like to raise your hand. We have a smaller group today, so I don't mind if you maybe just come off mute and ask your question verbally. That should be fine. I see a thumbs up here from Ted. Ted, do you have a question or are you giving us a thumbs up for the presentation?
I have a question for Dr. Kasner.
Okay, great.
Hi, Dr. Kasner. I'm Ted Peterson. I'm father of Ida Peterson, 30, AML, Runx 1, 20 months at Hopkins. First transplant, she was MRD. Second transplant, cleared. We're about at day 148. Blood test tomorrow, of course. And actually, Ida feels pretty good. My question to you is, what I know we work with Dr. Mark Levis, who I'm sure you know. He's a head of adult leukemia at Hopkins, and he's just been great. But what are we watching for, both physically and, by the time we do a blood, we're now into 1 month visits to Dr. Levis, and he'll see whatever we need to see. But when I see those tomorrow, just like you said, I'll see them before he will, 10 minutes before he sees my daughter and her husband. What are we watching for any sort of relapse? And secondly, what would it be watching for in the month or 2 months or 3 months in between, in your opinion, relative, if you didn't see tests, but you were watching the patient? Thank you.
So for the tests and the patient, honestly, post-transplant is a complicated period. And so a lot of things that might make you worried somebody is relapsing, like let's say a falling white blood cell count, could also be related to graft versus host disease or to a virus and so my point is not to complicate, but to say that it's all in context. And so I do know Dr. Levis actually was just at a leukemia conference with him, because we finally got to go back to personal conferences. So yay. And he's great, and he will take the whole picture into consideration. And so right. If you see something that looks different, like a white count that's falling significantly, you want your daughter to talk to him about it and to ask the questions and to say, like, are you concerned about this? Is this, what should we be thinking about? Sometimes it's just a blip. I mean, really any virus at this point, so close to transplant, can affect blood counts. And so the first thing I'll say to my patient is, did you have a cold last week? Have you not been feeling yourself? So what
white blood cells are the indicator.
It can be again, let's say falling platelets, right?
And so I'm not wishing, believe me, she's my child. I'm not wishing for this. I was just,
yeah. I get it.
And he's been great. But, Mark Levis is the best. I mean, he's been so open. You were probably up in British Columbia with him. I don't know if that's.
That's where I was with him. Yeah.
So we know his movements as well. I'm not trying to be cute or short here, but let me ask you, in that period, it's occurred to me as dad, during that period, I ask Ida every day, we FaceTime every day. How do you feel? What do you, what are we looking for? Nosebleeds or
it's also a hard question. And what I tell my patients and their families, right, is that there's two sides of this coin, right? So one is that normal things are going to happen to you, even though you've had 2 transplants. So you're going to have a normal ache or pain. You're going to have a normal cold, right? But what I always say is, if it is concerning to you, even if it is normal and and we can say it's normal, always call, right? So this close to transplant, it's going to be up days and down days, and there's going to be normal things. And the better you feel, the more you're going to start doing things that bring on those normal aches and pains. That's sort of a common thing that happens to my patients is they start feeling better and they decide they're going to start riding their bike. And then I get, you know, my leg is hurting like the way it hurt when I got diagnosed. And we sort of have to talk through is, well, your blood counts look totally normal or whatever. So what I really say is if it concerns her or her husband or you, it's always better to call. And so, or to give it, you know, if it's not 103 fever, you can give it 6 hours or 12 hours or 24 hours, and then call if it's still concerning. Because there isn't a single answer to what I hope will never come. I hope she never relapses, but the presentation is going to be different. And confusingly, after transplant, it's often different than the original presentation because leukemic relapse is often different than it was the first time. So
Right. Thank
ask
you.
her
Very
every
helpful.
day how she's feeling. And if you're worried, I'll tell you as an oncologist, I always encourage spying. So sometimes the patient doesn't want to tell. So I rely on my patients' partners and their children and their parents to spy for me and to tell me the truth about what's really happening with them. So.
Well, great. Thank you very much.
You're welcome.
Great. Does anybody like to come off mute? Let me see if I have any other hands raised or just give it a second of silence for anybody that'd like to pose any questions.
Katie, I have a question.
Okay,
Hi,
great.
Dr. Kasner.
Hi.
This, I don't think there is an easy answer to, but I'm just curious to hear your response. I've learned through my husband's journey that I was always thinking that the white blood cell count would be high on the initial diagnosis, but I've since learned that there can be cases where people have low white blood cell counts in the initial diagnosis of AML. And I guess that seems so confusing to me. And I wonder if you could just talk about that for a minute.
I can actually, and I'm gonna go back to my favorite. I wonder if I can still share my screen.
Here, I can stop it and you can restart.
Okay. So I am gonna go back. I'm gonna go back to my favorite picture, which is this one right here. Okay. So if the leukemia fills up the bone marrow and doesn't leave the bone marrow, and why not? Because some just don't, they don't until later. Then what you see is this space that's got a lot of leukemia in the bone marrow, but not a lot of cells circulating anymore because there just is no more room for them to grow. And so that's one reason. And the other reason can be that people can develop leukemia out of other diseases, including something called myelodysplastic syndrome. So myelodysplastic syndrome is a related disorder in which the cells are trying really, really hard, right? So they fill the bone marrow, but they're just not normal or functional. And so they can't leave the bone marrow. And so in that case, you see not just leukemia in there, you actually see all different kinds of kind of weird looking cells, which is why it's called myelodysplastic, which basically means weird looking cells, but they can't come out into the blood, right? Because that's supposed to happen when normal cells like you can think of the bone marrow as like your training, your school, your preschool, middle school, high school. And then when you're done and you're trained and you're ready for your job, that's when you come out to the blood. So if you're either crowded out or non-functional, you'll see these low white cell presentations. Does that make sense?
Yes, thank you.
Good.
Okay, I see a raised hand from Pete. I'll let you take it away.
Good afternoon, Dr. Kasner. Pete Liston here. I'm a patient there at Jefferson AML. I've been treated for about 7 years. I'm about almost 7 years post-transplant, currently on Vidaza and venetoclax. And I have a question regarding the medication's effect on the blood cell numbers. Specifically, do they affect my white blood cells or my red blood cells, the medicines that I'm taking?
Without a doubt, right? So here's the problem with our therapies in general. They are not that specific, right? Oh, I'm going to go back to my favorite picture, right? Which is, I don't have to go back, but you saw it, right? When we killed the weeds, we killed the normal flowers too. And so here we're not really killing them. We're just kind of stun gunning them a little bit. But in order to the target, right? The leukemia target, it is not too far off. When I showed you that that all of them come from a single cell when they're growing. So they're all pretty closely related, including the red cells, right? Red cells actually come from myeloid precursors, which I always think is very interesting. And so red cells, platelets, white cells, they're all very closely related. And when you target that system, even to just keep the leukemia away or, for whatever purpose, it's very difficult not to affect the counts at all. And so what I'm guessing is going on with you is that people are doing dose adjustments to try to keep the numbers, especially with azacitidine and Vidaza. It's a challenge, but we work hard to try to sort of find the right number of days of Vidaza of Vidaza and of venetoclax to try to get the numbers to be not transfusion dependent and to be safe and not people not to get infections. But 100% those meds they're kind of cross reacting. They're like weed killing a little bit your normal flowers.
So let me ask one follow-on question also. The forecast right now is that my team will have me off of treatment about a year from now. I've been anemic, borderline anemic for many years, 10, 15 years. Is there hope that after I'm off treatment, my red blood cells will rebound?
There is. It's certainly not guaranteed. And I'll tell you, one of the reasons is because when we batter your bone, we take the blame, right? Because we also take the glory when you do well. We also take the blame. So when we've battered your bone marrow for years and years and years and years, it sometimes doesn't recover completely, or sometimes it takes a long time. But yes, there is a very good reason to believe that when you come off therapy completely, it will allow your bone marrow to recover.
Thank you.
I'll hope it does.
Me
You're
too.
welcome.
Great. I'm not seeing anything pop up in the chat. So would anybody else like to pose a question or make a comment to Dr. Kasner?
I have one more question for Dr. Kasner. I was going to ask about, you mentioned the level of blasts, that there can be some blasts and it not be concerning and not be necessarily leukemia. And you're right. I was sort of thinking of if there's blast, it's not good. But is there a level to which you guys say, okay, below this level is okay and considered not remission or not relapse?
Yeah, so it's more of a what are those cells really question. So the name for the recovering cells that look like blasts is actually hematogon. And so we use things like flow cytometry to differentiate whether those cells are leukemic cells or hematogons. But when they just read it on a differential on the blood thing, on the automated or even the manual differentials that come on your blood counts, that's not enough information to tell us. So it's a little scenario dependent. Like I said, it's more common to see in recovery. So if you're recovering from a cycle of chemotherapy, or you've gotten growth factors to help with recovery, and you see some of these cells, that's a place where I'd be like, let's just wait and see what happens with those. They'll probably just go away. So it's both scenario dependent, and also you can use flow cytometry to identify, not 100% of the time, because sometimes they look super similar, but a lot of the time you can differentiate between these sort of hematogons, these growing normal cells, and a leukemic blast.
Great.
Thank you.
I have maybe not a question, but maybe have you provide some thoughts or advice on the topic. It's kind of come up a little bit today. And while you've showed us that labs are very complex and should be definitely taken into consideration with our medical team, we do have access to them and we get them early. And I know that can cause probably some anxiety having these numbers in front of us and not being able to talk to the professional at the time, but also having those is empowering. And if we know a little bit of what we're looking at, it's helpful in creating these intelligent conversations with our providers. So I'm wondering what the middle ground looks like between maybe this anxious state we could be in, but also versus maybe not knowing much about what we're looking at and waiting for the medical team to tell us. So any advice or thoughts on that middle ground?
Yeah, so what I try to do with my patients and what I encourage you to do is actually to preempt it with a discussion about what you should be looking for. So what I mean by that is if you're a week into your chemotherapy cycle, your numbers should be falling. Okay, but that means it's working. That's what's supposed to happen. That's because our therapy is weed killer and it doesn't differentiate. So sort of having a preemptive discussion and taking notes, because how are you going to remember what, week 1 and 2 and maybe 3 blood counts will be falling. We'll need blood transfusions, and write down, you'll need a transfusion when your hemoglobin's less than 7, when your platelet count's less than, it sort of depends how frequently you're getting a check, 10 or 20, and sort of so that you're not feeling anxious when you see that blood count falling. And then weeks 4, weeks 5, week 6 should be slowly rising. You might get to see one of those little blasts going up in there that you don't need to worry about. So sort of a preemptive discussion, because you are going to see them sooner. And I do think people, unfortunately, who are going through this get to be quite expert at all of these things. And soon can sort of tell me. But in the beginning, it's very difficult and it can be very anxiety provoking, and just having an outline for yourself. What can I expect for these first few weeks? It should be, by the end of the first week, it should be falling, so that you're not worried if it hasn't fallen in the first day, or by the end, it depends on the therapy. So getting an outline from and there's therapies now that cause the counts to rise, not fall. And that's something called differentiation syndrome, where the therapy actually causes the cells to grow up before they die. And so if you're on one of those therapies, you might watch the counts rise and rise and rise. It might feel like, oh no, my leukemia is getting worse and worse and worse, but actually that's the drug working. So I think the key to making yourself less anxious is a conversation before about what your counts should be looking like approximately over the next days, weeks, months.
That's excellent. Thank you. All right, well, we'll wrap up unless I have anybody else pop in. Let me read the chat here. Thank you. This was very interesting and clear.
Very welcome.
Anybody else before we wrap up? Okay, well, let me share one last announcement. Our next Adult AML Chapter meeting will take place on June 23rd from 3 to 4 p.m. Eastern. Lindley Swinning, who is HealthTree's fitness director, is going to be joining us for a fitness event, and you can find the registration page for this event and others by visiting healthtree.org/AML/community/events. Once again, thank you to our HealthTree Community for AML event sponsors, Bristol Myers Squibb, Amgen, Genentech, AbbVie, and Jazz Pharmaceuticals. And thank you for helping us build a strong HealthTree community for AML. I appreciate you all. Hope you each have a great rest of your evening and really hope to see you all again on June 23rd.